Hello, everyone. My name is Emma Paulino. I'm a community pharmacist. I'm a community pharmacist from Portugal, and I'm very happy to welcome you today to our webinar on delivering asthma right care for community pharmacists. So we have a full program for you today, but we will still have time for you to ask questions. So I will be announcing how you can do that throughout the session in a few minutes. But first, let me introduce you to our distinguished panel of today. I will be introducing the whole panel already because we will have a dynamic session in which all of the speakers will be delivering not only once, but also they will be exchanging many times during the program. So it is easier that I present all of them to you today. First and foremost, let me tell you that this is a collaboration webinar between FIP, the International Pharmaceutical Federation, and the IPCRG, the International Primary Care Respiratory Group. So thank you very much to both boards who decided to collaborate to disseminate information about this important topic. So we will have 1.5 hours for our event, and let me introduce your speakers for today. I've already mentioned that I am Emma Paulino. I'm a community pharmacist from Portugal. I'm also professional secretary at the International Pharmaceutical Federation. The next presenter I would like to introduce is Darush Attarzadeh. He's a pharmacist, behavior change specialist, and international respiratory trainer. He has presented at various national and international conferences, including many different conferences, and was asked to help review the national training standards for smoking cessation. He's an active teacher and follower of the IPCRG Asthma Right Care social movement, which we will be presenting to you today, and enjoys spreading positive messages on how people can live much better with asthma. Darush has published more than 20 clinical papers and writes teaching modules on various pharmacy platforms. He has been recognized by his healthcare peers at the 2019 PCPA GP Pharmacist Awards for Excellence. So welcome, Darush. The next speaker I would like to introduce to you is Francesc Moranta Ribas. Francesc is a practicing pharmacist in a community pharmacy in Mallorca, in Spain. He is a member of the Respiratory Task Force of the Spanish Society of Community Pharmacists, CEFAC, a member of the Spanish Primary Care Respiratory Group, and a member of the Spanish Asthma Right Care program. He is also part of the IPCRG Asthma Right Care community pharmacy team. Francesc has been involved in pharmacist education for many years in respiratory care and other areas. In particular, he has been teaching how to improve inhaler technique and providing education on asthma and COPD to community pharmacists from 2003. So welcome, Francesc. And the last speaker for today is Debbie Rigby. Debbie is an advanced practice pharmacist with postgraduate qualifications in clinical pharmacy, geriatrics, and respiratory medicine. Debbie is a member of Lung Foundation Australia COPD Advisory Committee and Primary Care Committee and the International Primary Care Respiratory Group. Debbie is leading the National Asthma Council implementation of Asthma Right Care in Australia. She currently conducts home medicine reviews and provides medicines education to pharmacists, nurses, GPs, and other health professionals through her company, Pharm Education. So welcome, Darush, Francesc, and Debbie to our event. Like I said, we have a full program for you today. Let me first have some announcements, and then I will outline the program that we have and the learning objectives. So for your information, this webinar is being recorded and live streamed via YouTube and FIP events website. The recording will be available on our website, and you can see the link on the slide. You may ask questions using the question box provided. So we ask that you use the chat box to introduce yourself, but if you would like to have a question for any one of the speakers, then we ask you to use the question box provided. You are welcome to provide feedback to webinars@fip.org. We really welcome your follow-up feedback on what you thought about the session. And we also obviously welcome you to become a member of FIP at the link also provided on the website. As for today's program, we will begin with a short introduction on Asthma Right Care, a short update afterwards on GINA 2021. We will give some practical examples of Asthma Right Care. We will then move to how pharmacists can contribute as a profession to Asthma Right Care, then about the importance of successful pharmacist-GP interaction within the context of Asthma Right Care. We will highlight and describe some barriers and enablers for change. And then we will have a call to action for you to get excited and motivated to begin also participating in this international movement. And we will have some time for discussion so that you can have your questions answered by the panel. As for learning objectives, by the end of this webinar, we expect participants will have received a critical update on international asthma guidelines and the implications for pharmacists. We expect you to learn about tools available to start a conversation with patients and prescribers about Asthma Right Care, including how to address over-reliance on SABA and how to use the right medicines in the right way. And also discuss what opportunities, motivation, and capabilities are needed to bring about change. So hopefully we will achieve all of these aims by the end of the session today. So let me just give you a very short introduction to Asthma Right Care and what we mean when we are talking about Asthma Right Care. So in the next slide, just waiting for the slides to upload. Can we move to the next slide, please? Okay, we had a short technical problem with our slides, but we will soon have it fixed. Just a moment, please. Thank you, Anikan. So what is the problem? Is there a problem? So we know that every system is perfectly designed to get the results it gets. So that is both intended and unintended consequences are designed into our systems. And what we know about asthma is that asthma illustrates all the things wrong with healthcare systems globally. So we have unwarranted variation, which is not due to disease difference, but most possibly to differences in how care is provided. We have harm because we know that many patients with asthma are not well controlled and often suffer adverse drug reactions from their medicines as well. We have failure to prevent the disease and disability, and this is a problem, of course, because we have a disease that is progressing and this affects patients' quality of life. We have a waste of human and physical resources through low value activity, because when we don't focus on prevention, obviously, then we are focusing on resolving complicated and complex asthma complications that could have been avoided. And we have inequity in terms of access of people to care and also the outcomes of their therapy. So what has the IPCRG done for the past few years? Can we go to the next slide? So we have to identify what's wrong so that we can change for improvement. So we know from speaking with our peers that SABA use needs major improvement. So people are using short-term agonists quite often, which means that the disease is not well controlled. We know that the first SABA conversations affect their future use. So we have to be very active in the first phases of disease. We know that healthcare professionals need to want change. So we have to involve everyone in this effort. We also unfortunately know that in terms of public policy and national guidelines, asthma is a low priority for change. So what we want to do in the Asthma Right Care movement and the various steps that we have to introduce to make sure that change happens is that you first have to gain acceptance that improvement is needed. You have to disrupt comfort with the way things are done. So you have to interact with healthcare professionals and patients themselves. You have to apply the evidence about achieving change at a scale. You then have to inspire followers because you can't do everything alone. So you have to involve a lot of different people. And you have to teach right care. What is right care? And what is it about anti-inflammatory therapy and continuous care that you can do in terms of improving patients' quality of life? So in the next slide, you have to do the right things if you want right care. And what is right care? Is doing the right things and only the right things in the right way for the right people at the right time in the right place, whatever that means in the local context. So there's a lot of things that has to be right in order to achieve right care. And you have to change it according to the local context. So maybe I can ask Anikan already to click various times because we have a lot of animations in this slide. This is only to show, I think that's okay. This is only to show that Asthma Right Care has grown in terms of involving more geographies, in terms of this social movement. We want this disruption to occur in as many territories as possible. We have to involve many and all parts of the healthcare system that are important, from policy to healthcare professionals, but also involve patients in this effort. And you have to involve patient organizations and network with them to understand how they would like to get involved and how they can contribute to Asthma Right Care. You have to understand, obviously, the local context, and you have to collect information about the status of asthma care in your country. And then what we have to implement is to go deeper into a paradigm and behavior shift in which you move from having an unconscious incompetence and acknowledge, and for this you have to move through a stage where you acknowledge that something needs to be done and that you have to learn more to a mastery level where you have a conscious competence of unconscious incompetence. And for this, the IPCRG has developed a set of tools that are useful for us healthcare professionals to use in our practice in order to recognize what we don't know and in order to act on what we know and change what is wrong so that we can achieve Asthma Right Care. We will be discussing many of these tools in the session today. So in the next slide, I will give the floor to Francesc, who will give us a short update of GINA 2021 in terms of SABA use, so we can understand where the problem still lies, and then we will discuss how you can help to achieve Asthma Right Care and improve our patients' quality of life. Francesc, the floor is yours.
Many thanks, Emma. I'm going to explain the latest update of GINA report in terms of SABA use. Can we move? Okay. But first of all, I would like to ensure that everyone here knows what GINA means. The acronym GINA means Global Initiative for Asthma. It's an international non-profit organization created in 1993 under the auspices of some healthcare organizations from the US and the World Health Organization. GINA strives to increase awareness of asthma among health professionals, health authorities, and the general public. Their main goals include improving diagnosis, management, and prevention of asthma. Can we move, please? Okay. The GINA launch every year its strategy report is updated every year, and those recommendations are released as part of an integrated asthma strategy for symptom control and risk reduction. Can we move? Okay, no, sorry. The previous one, please. Before going on, I am going to launch a poll. We will share the results at the end of my session. Can we launch? Okay. According to the current recommendations, which do you think is the preferred reliever in asthma treatment? Salbutamol, terbutaline, formoterol, inhaled corticosteroids, ICS, or ICS in combination with formoterol? Now you can vote. We will share the results at the end. Okay, can we move now? Okay, now let me start by going back to 2019. In April 2019, the GINA published their recommendations, and that might be considered the most fundamental change in asthma management for 30 years. And those recommendations are that the treatment of asthma with short-acting bronchodilators alone, SABA, was no longer recommended for adults and adolescents. Can we move, please? But what are the reasons why GINA published those recommendations? Okay, despite inhaled SABAs being highly effective, quickly relieving asthma symptoms, it has been proven that patients whose asthma was treated with SABA alone were at risk of urgent asthma-related healthcare and even of asthma-related death in comparison with those who were treated with ICS. Moreover, dispensing of 3 canisters per year or more was associated with higher risk of severe exacerbations. In addition, dispensing of 12 canisters per year or more was associated with much higher risk of death. Can we move, please? Okay. Thereby, GINA published within its annual strategy report this graphic in 2020, where you can see how the preferred reliever was as needed low dose of inhaled corticosteroids and formoterol. Please, the next. Okay. And finally, we arrive at the latest annual report in 2021, this year, where GINA's recommendations have gone even further, as you can see here. There are 2 tracks, and the preferred track is the track 1, where the controller and the preferred reliever are as needed low dose of inhaled corticosteroids in combination with formoterol, both as a controller and as a reliever. Can we move to the next? Okay, as you can see here, the preferred track is using inhaled corticosteroids and formoterol as reliever reduces the risk of exacerbations in comparison with using a SABA reliever. And the alternative track is the track 2, where in some cases it's possible to use the SABAs as relievers. Can we move to the next slide? Okay. But which are the reasons why GINA has recently published these new recommendations? Well, using inhaler corticosteroids and formoterol as reliever reduces the risk of exacerbations in comparison with using a SABA reliever, with similar symptom control and similar lung function. The track 2 is only an alternative approach, and the use of this track 2 is only is not possible or is not preferred by a patient with no exacerbations on their current controller therapy. Okay, if the patient is not well controlled, they cannot use this track 2. And it's important to take into account that before considering a regimen with SABA reliever, it's necessary to consider if the patient is likely to be adherent with daily controller. If not, they will be exposed to the risks of SABA-only treatment. And now we can share the results of the poll, please. Okay. Well, don't worry about that. I expect these results. Salbutamol is the most voted, but now, thanks to my session, you all will never forget that the preferred reliever is from now on inhaler corticosteroids and formoterol. Thank you very much for your attention.
Thanks, Francesc, for that, and thanks to FIP for inviting me along an IPCIG. So my name is Darush, and I'll be talking to you about some of the tools, excellent tools that the IPCIG have put together that will help us in community pharmacy and all sectors of pharmacy. So when it comes to making every contact count, that's something we're going to be touching on. And we're going to be touching on, as Francesc was talking about, when a person uses the short-acting beta-2 agonist by itself, it's got no anti-inflammatory agent in there. There is risks to patients. So we've developed a tool to help us understand what the numbers are. We're going to talk about that. We're also going to familiarize ourselves, if we're not aware already, around what good asthma looks like. And we have tools that we can use in the community pharmacy to make people aware of what good asthma looks like, and also understanding people's beliefs around the short-acting beta-2 agonists, and also the inhaled corticosteroids or anti-inflammatory treatments. We have fun playing cards we'll talk about as well when we're thinking of health promotion events. Living well with asthma is definitely something that could be achieved. So let's do this in a fun way in our community pharmacies, for example. Now, a lot of this stuff can be done in very short periods of time. We're going to talk about how it can be done in 30 seconds, for example, like how we can do very brief advice. And we're going to talk about the acronyms like SIMPLES. Next slide, please. So many of you all across the world will be working in pharmacies, and in England we say you're never more than 20 minutes away from a community pharmacy. We are seen as healthy living centres or well-being centres. We can offer lots of free support many of the time, as well as, of course, dealing with promoting and protecting health rather than just treating it. So to become a follower of this movement, Asthma Right Care movement, or as I call it over in England, becoming a SABA Guardian, why not develop these skills, which we'll talk about briefly today, on how we can just raise the subject in a comfortable way. So, for example, I like to always say that we're offering a new service that, and we've helped lots of people. For example, if we want to go smoke-free, we've helped lots of people go smoke-free in our pharmacy. If we want to help people with regards to spacer awareness, we can ask, do you have a spacer with your metered dose inhaler? And when was it last changed? 2 questions, simple questions, just to raise awareness of the importance of using a spacer with your inhaler. But for the SABA Guardian, we're going to talk about how we can raise the subject of that within the pharmacy. Next slide, please. So where we can do this and the tools we can use, we can do this, of course, with our peers in community pharmacy. So in my hand in that pharmacy, I've got the slide rule, which I'm going to touch on. And then when we're out and about working, for example, with our GP colleagues or nurse colleagues in GP practices, or out and about running patient group sessions, we can raise awareness of the important role of community pharmacy or pharmacists when it comes to raising and making every contact count. Next slide, please. So what I'm going to do is just touch on this. I won't turn this one into a poll because of time, but what I would say is this prescription arrived in the community pharmacy up the road where I sometimes locum. And I saw it had ICS formoterol on there, but it also had a separate SABA item on the prescription. So this was for a 17-year-old living with asthma. So when you see a prescription like this, I wonder what crosses your mind, because I felt very uncomfortable when I saw this prescription and wanted to challenge the prescriber. So some of the things that would have come to mind was that why was the SABA being prescribed separate to the ICS formoterol? The reason why is the ICS formoterol is being used as a maintenance treatment, but they're using a separate inhaler as a reliever. What also crosses my mind is why is one of them in a metered dose inhaler and the other one in a dry powder inhaler? Because the technique is very different for both. But what was most alarming for me is the dosage here, because it says 2 puffs 4 times a day when required. And I know if a patient sees that sort of dosage on there, is it going to be very helpful for them? Because this blue inhaler, or it's blue in the UK, this SABA should only be used in emergencies. So next slide, please. So I would have felt, and I did feel very uncomfortable with this scenario, and would have contacted the prescriber just to say, actually, this label isn't very helpful for the patient, because actually this blue inhaler should only be used for emergency treatment. If you have to use the blue inhaler more than twice a week, or the SABA more than twice a week, then that person hasn't got fully controlled asthma. So what I would have also done is looked at the patient medication record, which we have in, many of us will have in our countries, just to count the number of inhalers that person may have had of the blue, just to see if that person has got good asthma control. So next slide, please. The other thing I would have, of course, checked, which is very, very important, is whether how many of the ICS formoterol prescriptions were picked up, because asthma is a condition of inflammation. And if we don't treat the condition of inflammation, then then that person is definitely going to be at risk. So that blue emergency treatment, what may have been more helpful on the label would have been to say something along the lines of inhale 1 or 2 puffs for cough, wheeze, or shortness of breath, and get medical help if this doesn't help, or if this relief doesn't last for 4 hours. It is quite a long label, but it is far more useful than what's on there currently. And so what would be interesting is to find out in your countries how you would describe SABA. Do you describe it as a reliever, a rescue treatment, emergency, or blue inhaler, as we say in England? Next slide, please. So one of the great tools that we have as part of the International Primary Care Respiratory Group is this slide rule. And this helps us understand the numbers. So this 17-year-old patient was on seven blue Ventolins or canisters a year. Each canister contains 200 puffs. One dose is 1 to 2 puffs. So potentially, if this person has used every single last puff over that 12-month period, they would have had 1,400 breathless moments, or 700 to 1,400 breathless moments. I don't feel comfortable with that as a clinician. And I know that if I had this slide rule, which I do in hand, this would mean this person is using 4 puffs a day. And remember, a person with good asthma control shouldn't need to use their SABA more than twice a week. So you can see why GINA has changed the way they think about how we manage asthma. So the next slide, please. At the back of the slide rule, we can ask patients, and what I like to do is, if I'm doing a health promotion event, I would have my T-shirt on and I'd be saying, we're running a new program. We're raising awareness of this inhaler. Do you know much about these inhalers that you're using? If I had literally 60 seconds to talk about this, I would ask the person, you know, do you know how many canisters you've had in the last 12 months, just to get an idea of what's going on in their mind. And I would also say to the person that on a scale of 1 to 10, how important do you think it is for you to get an asthma review? So the slide rule is a very positive tool that we've been using effectively across the world. Next slide, please. So I like to have lung tubes as well, because the way I look at asthma, it's a variable condition, it's episodic. And this person, as in this lung tube, which I've got in the picture there, is showing inflammation. And if a person understands that SABA does not treat the underlying inflammation, then I think that hopefully will help. It only works on the outside of the airways, and it helps with the bronchoconstriction. But the only way to treat the inflammation is by using a regular low dose of inhaled corticosteroid, for example. And we can help that person increase their lung openness. So would you like to be breathing through a straw or a hose pipe? I know what I'd rather be breathing through. Next slide, please. So the other things that we've got, the fun playing cards, so to speak, we've got quite a number of them. Some of them are metaphors, or some of them are similes, and some of them are challenging statements. We can do so much in pharmacy to support our patients. And one of the things that we can't assume is we can't assume a person knows how to use their inhaler. And a lot of us will be experts, hopefully, in helping people, coach people how to use their inhalers well. But many people can't use their inhalers, and this is why that coaching is key. And if they're not using regular preventer in treatment, then potentially only around 12% of that drug may be reaching their site of action. So this is something to really for us to think about. And there's a simile and metaphor that may help. And I do like the metaphor on the right, saying how the blue inhaler, or the SABA, is like dampening down a fire. But to put out the embers and to stop it flaring up, you need to use the regular courses of inhaled corticosteroids, low doses. Next slide, please. And next again. So what we'll find is, again, I find sometimes people, when they hear the word steroid, they get a little bit concerned. They might think, aren't there too many side effects to steroids? And so some of the terminology that we can use will help a person, I think, because if you're getting a low dose of inhaled corticosteroid, rather than courses of oral corticosteroids, which will have far more side effects, a person can maintain that natural balance. We all naturally release steroids in our body anyway, but our body reacts, unfortunately, if you have asthma, it may react too strongly to some of these triggers. And so to maintain that natural balance, what we can do is use a very low dose of inhaled corticosteroid with good inhaler technique, of course. Okay, next slide, please. And so sometimes, and this is a self-test that can be done in a community pharmacy, for example. It's looking at beliefs, because sometimes people in various countries across the world, and I know it varies a lot, but there is strong beliefs about even people being labeled as having asthma, for example. But it's just to understand the different medicines and how they work and what they're for. So this reliever Reliance test is a very short questionnaire, which you can give out to a patient if they're waiting for a prescription. It will ask a few questions around what that person's beliefs are around that blue inhaler. Do they believe it treats the symptoms? Is it the best way to keep on top of their asthma? Is it the inhaler that they need to rely on or not rely on? But it's 5 structured questions, which I find really work well if a person is waiting for their prescription and still strongly believe that asthma is a condition of bronchoconstriction and not a condition of inflammation. And so I think this, alongside the other tools we've got, will help us in our pharmacies. Next slide, please. So coming back to our 17-year-old, who, by the way, is not living very well with asthma. He's living pretty badly with asthma. He's using his SABA regularly. He's waking up at night, and he's getting daytime symptoms. He's also avoiding, he was part of the football team, but he actually goes in goal rather than actually play outfield because he doesn't want to exert himself too much, which is understandable. So he avoids exercise. But what we want to do is help him understand that regular use of his inhaled corticosteroid and LABA formoterol, which he's only picked up 2, will really help keep those symptoms at bay. And that's something we can really help empower and educate patients on. Next slide, please. So one of the things that I like to raise is that the actual blue or the SABA contains 200 canisters. I don't know how many of us ever do this, but I always say to a person, if they're managing their asthma with track 2 of GINA, for example, they're using a separate inhaled corticosteroid and they're using short-acting beta-2 agonist as well. I'll always say to that patient that one of these canisters should actually last you 6 months because it contains 200 puffs. And if you're needing to use more than that, then it may indicate your asthma may not be fully controlled. If you're finding that a person needs 1 or 2 extra because they're going for, they need it for their work or for school or something along those lines, that's obviously different. That's fair enough. But one of the things I'd be discussing is this person is already on ICS formoterol. Is there a way that we can maybe talk about using it as a possible maintenance and reliever therapy, which is licensed in many countries as well? Or if I'm really busy and I haven't really got time to discuss a lot of these things in the busy pharmacy, will I pull out my reliever Reliance test as a self-test that the person can fill out? Or will I just get out the slide rule, which is really, really quite nice, and it's got, I know you can't see it from there very well, but it does move along as well, and you can show the patient the number. A lot of people like to know what their number is and know potentially if they're at risk. And this is the whole thing around making every contact count, making it appealing. Next slide, please. So some of the questions and some of the things that will be crossing my mind. Whenever a prescription for short-acting beta-2 agonist comes on, or if it's bought over the counter, I'll be asking, is it for asthma? I'll be thinking about the asthma control test as a self-test, because I would want to know if a person is waking up at night, having daytime symptoms, and if they're needing to use their SABA inhaler regularly. And actually, how well do they think their asthma is controlled? Because there are a lot of people who live very badly with asthma, but they don't realize that this is not normal. You know, they'll live with symptoms on a day-to-day basis, not knowing this actually doesn't need to be the case. I'll also be trying to identify the number of SABA that person's had over a 12-month period and number of ICS that's being picked up. Next slide, please. And I'll be thinking those people who are at risk, I'll be thinking of referral. So knowing what good asthma looks like, knowing what bad asthma looks like is something that we can't assume people know. A lot of time is something that's not spent with people sometimes. And so I'll be thinking, I haven't got time in the pharmacy right now, but I'll do that initial contact and I'll make some initial awareness of what good asthma can look like and what a patient should be demanding, and also how to refer on to the clinician and make our local clinicians aware of the services that we'll be offering in the pharmacy. So next slide, please. So inhaler technique, over in England, we've got over 120 different inhalers now. There's so many inhalers, we're swamped by it. But what's important is we can keep it simple. There are generally three classes of device. You have dry powder inhalers, you'd have metered dose inhalers, and you'd have soft mist inhalers. And you obviously not forget spacers, how important that is. I mean, believe it or not, 9 out of 10 of us healthcare professionals may make a mistake when using a metered dose inhaler by itself. So it's really, really important that we know how to use device and coach people. Next slide, please. So maintenance and reliever therapy, I'm conscious of time because I know our other speakers need to speak to, but just be aware that that's a licensed treatment that's it's been around for a little while now. And there's another option to people that have the fixed doses of ICS and LABA, so ICS alone. You might have people on these fixed doses. And what can happen if you're noticing potentially a person is non-adherent to their inhaled corticosteroids? This is where GINA has now recommended anti-inflammatory reliever. But for people who maybe are adherent, but they may be using their SABA quite a lot, I consider maintenance and reliever therapy is a good option because they can use their formoterol, which acts just as quickly as salbutamol or terbutaline, as their reliever, but it's got background inhaled corticosteroid, which is important. But you need to look at the SPC, the summary of product and characteristics of each of those treatments to see what the licensing is. Next slide, please. And so just to summarize really this last bit here is there's some acronyms. IPCRG have got some excellent desktop helpers, which I love to use. This acronym SIMPLES looks at how we can help with management, smoking cessation. We can offer that in 30 seconds. Very brief advice, we call it. We call it the ask, advise, and act. I've got that on my next slide. Inhaler technique, we're experts in that, a lot of us. Monitoring patients' adherence to inhaled corticosteroids, which is so key. Pharmacotherapy options, finding out what people's understanding are. Potencies of medications. We are medicines experts ultimately, but we're also behavior change specialists. We're also very good listeners and big part of empowering patients and involved in shared decision making and signposting. Next slide, please. So for very brief advice, the ask, advise, and act, the way I would normally bring it up in England would be, do you smoke or do you live with a smoker? I would always think about exposure to secondhand smoke and think of indoor and outdoor pollution as well. I'll be thinking of advising the person the best way to stop is with a combination of support and treatment, which we do have available in our pharmacy, for example. And the act part is to obviously act on the person's response. If they're not interested, then obviously say, our door is always open to you. We can always support you. And if they are interested, then obviously recruit them onto your special program and let them know what you have available. Next slide, please. Over to you, Francesc.
Yes, thank you, Darush. Okay, I am going to talk about pharmacists as a profession, working with peers, community pharmacy societies to improve capability, opportunities, and motivation. Next, please. Okay, but let me start by telling a story. In Spain, as in many countries, the national regulatory system allows pharmacists to dispense SABA without a prescription for emergency use only. In Spain, is not allowed to sell SABA as over-the-counter. However, over time, the implementation of this regulation was relaxing to include non-emergency use as if it were an over-the-counter medicine. As a result, for some people, it has become their main treatment pathway. Can we move, please? Okay. Going back to 2019, here we have the bestsellers brands in Spain. And you can see as Ventolin, the most famous brand name for salbutamol, was one of the bestsellers brands in Spain, more than 7 million canisters per year. And it was estimated that only 60% of those canisters were sold by an ordinary way. 40% of SABAs were supplied by private prescriptions, urgent need emergency, or discharge reports, even inappropriate dispensations. So, according to GINA's recommendations, there was an urgent need to get a change in terms of SABA use. Next, please. Can we move? Okay. But in order to explain that, we thought that we need a behavior change. Instead of simply providing the SABA canister on demand, we proposed that community pharmacists took advantage of this teachable moment, offering accurate information and referring the individual to follow up with their primary care physician when necessary. As you can see in the picture, the pharmacist is located at the center of the picture, between the patient and the physician. And we thought that we have to take advantage of this place. Can we move? Okay, in order to explain that necessary behavior change, we are going to use the COMB model. The COMB model of behavior is used to identify what needs to be changed in order to apply a new behavior. It identifies 3 factors that need to be present in order to achieve that desired change: capability, opportunity, and motivation. Next, please. But let me talk in deeper about every single factor. Capability is related to knowledge, skills, and abilities to engage in the behavior. Motivation is related to brain processes which direct our decisions and behaviors. And opportunity is related to outside factors which make the behavior possible. Next, please. Okay, in terms of opportunity, what may a simple community pharmacist believe about selling SABA without restriction. They could believe that they could think that it is easier to keep the customer happy by dispensing SABA without restriction. But we thought that the community pharmacist is ideally placed to identify a red flag when a SABA is requested over the counter. Moreover, pharmacists should take advantage of that moment to initiate conversations about how too much SABA and too little anti-inflammatory treatment is not the right way to control symptoms and can cause harm and waste. Can we move, please? Okay, in terms of motivation, what do you think when you spot a poorly controlled asthma patient in the practice? Some pharmacists could think that I may spot a problem, but I'm not confident enough to challenge the prescriber. Moreover, I could lose sales. Well, we think that the pharmacist behavior change leads to loyalty to a specific pharmacy and greater confidence in the pharmacist's role as a healthcare provider, not a retailer. Nevertheless, regulators should encourage right use of the emergency supply services and actively discourage misuse by offering pharmacists appropriate incentives to counsel patients. In addition, it's vital to work with multidisciplinary and interdisciplinary teams. Community pharmacists should be part of those teams as a healthcare professional. Pharmacists, as stakeholders in asthma management, should actively collaborate with the prescribers without fear, confidently. Next, please. This is an example of a multidisciplinary and interdisciplinary team where patients, nurses, physicians, and community pharmacists are working together in order to improve the Asthma Right Care. Next, please. In terms of capability, some of us could think, I am not an expert in Asthma Right Care. I do not even know how to start a conversation about SABA, but don't worry. As you can see from the previous session by Darush, the Asthma Right Care program has been developing tools to get the conversation going between patients with asthma and healthcare professionals about over-reliance on SABAs. Besides this, pharmacists should be up to date, checking recommendations from national and international guidelines. Moreover, regulators, pharmaceutical societies, and other organizations should invest more in pharmacist education. Can we move? Okay. And as a consequence of the behavior change, nowadays in Spain, a new approach to supplying SABA is possible by getting a stronger cooperation between community pharmacists and primary care physicians to combat poorly controlled asthma, and by considering that the prescriptions from a doctor is always necessary before dispensing SABA. As I have already told, it's very important, it's vital, the collaboration between different organizations, pharmacist societies, and other organizations in order to achieve the Asthma Right Care. In concrete, in Spain, it has been possible thanks to the collaboration between CEFAC, the delegation of GRAP of the EPCRG in Spain, GRAP, and some local professional college or pharmacists who have been working together in order to increase the awareness about the Asthma Right Care issue. Thank you very much.
So good evening, everybody, or evening from Australia anyway. I'd like to just spend the next few minutes talking about GP interaction and how we can address inappropriate prescribing. Next slide, thanks. So I think there's many touch points for community pharmacists. Clearly dispensing the first original prescription and then repeat or refill prescriptions is a real opportunity to have that conversation with the patient, but also, as we are bound to do, is to assess, is this prescription, is this medicine appropriate for the patient? So looking in the dispensing history will help, but I don't, as previous speakers have touched on, we should feel confident that we can ring the prescriber or the GP if you do have a concern around the patient's prescription. In Australia, we have salbutamol or Ventolin available over the counter for many years now, and I think we definitely have over-reliance on SABAs. A couple of years ago, there were 17 million SABAs dispensed, both on prescription as well as over the counter, and we've only got a population of 25 million. I think it's also, yes, identifying that over-reliance of SABAs, but also if a patient perhaps is asking for cough mixtures or expectorants over the counter, that might be an indication that their asthma is poorly controlled and hence an opportunity to discuss the patient with their GP or prescriber. And then also, as we know, that allergic rhinitis is a common comorbidity with asthma. And if you get your nose under control, better control of your allergic rhinitis, you're more likely to achieve better control of your asthma. So taking that opportunity, if a patient is asking for some medicines for their allergic rhinitis or hay fever, to then have that conversation with the patient, perhaps identify that the patient's asthma is not well controlled. The third touch point is medication reviews, and I know they're different throughout the world. Medicine use reviews, we call them meds checks. We've also got government funding for home medicine reviews or residential medication management reviews for people in aged care. And I think that's a comprehensive medication review, looking at all aspects. I do home medicine reviews regularly, and I take about an hour with the patient. So that's a real luxury. Most prescribers or GPs can't spend that amount of time with them. So helping the GPs understand what services, what programs you have that can provide a more comprehensive assessment of their asthma, as well as their total medication management. And lastly, the fourth opportunity, I think, for community pharmacists is true either multidisciplinary or interdisciplinary care in collaborative practice. We've got a big move towards, and I know it's very strong in the UK and other countries around Europe, that pharmacists embedded in general practice and embedded in aged care and many other opportunities there. So next slide, thanks. So it's not only about the medicines. As we all know, it's also effective treatment requires the right drug, but it also requires, in the case of asthma, the right device for the right patient. So again, there's many touch points in helping GPs to understand just what we can do to help in the care of patients with asthma. Clearly, if they don't take the drugs regularly, so their adherence is poor, if they have incorrect inhaler technique, those are things that we can have that perhaps more in-depth conversation, maybe just when you're dispensing the drugs, but also in those other pharmacy programs. And we can do things like checking their peak inspiratory flow rate, which will identify are they going to get the most benefit out of each type of device. And there's also these, patients coming into community pharmacies are very, coming to see us more than they're seeing their GP or prescriber. So we perhaps can see their change in cognition, decline in cognition, their understanding, their memory, trying to remember all those steps. Darish touched on the fact that people can be on 3 or 4 different devices and trying to keep a person to one particular type of device. So keeping them all on dry powder inhalers and soft mist inhalers like the Respimat, or on PMDIs using a spacer with them. And then, of course, having that conversation with the patient. What's their preference? Because if they don't like using the device, they're less likely to be adherent and to remember the correct technique. So there's lots of interventions that we can do in a community pharmacy setting. Next slide, thanks. So that GP collaboration, I think the first step really is helping GPs to understand just exactly what we can do through the community pharmacy, through whatever pharmacy programs you have. And underpinning that is our knowledge, having this up-to-date knowledge of the GINA strategy, for example, as well as your local guidelines. Because guidelines are changing, it's a radical change, the biggest change in 30 years for the GINA strategy to be recommending this move away from using SABAs in adults and adolescents towards using inhaled corticosteroids, and in particular the ICS formoterol for people with mild asthma on a PRN basis. We also in a pharmacy should have placebos for all the devices. It's challenging with so many, but reinforcing that people that are using PMDIs should be using the spacer and the correct type of spacer, and using devices or training devices like the inject dial, which I've illustrated there, around their inspiratory flow rate. And then the Asthma Right Care resources. Darish's been through a lot of them, and like anything, we've just got to feel confident and know how to use them. Practice on your start with your staff, practice by yourself, explaining these and using these resources, and helping GPs to understand that we have these resources and we have the time and the opportunity to help patients understand their asthma better, to use their devices correctly, and to get better control of their asthma. So next slide. So I now want to touch on the barriers and enablers. And next slide, thanks. There are a lot of barriers, and I was commissioned to write this editorial in Australian Prescriber quite a few years ago now, but this article's been cited many hundreds of times. And basically what I was saying, yes, there's really good evidence around the world that greater collaboration between general practitioners and pharmacists improves patient care. I did focus in this article on medication reviews, but I think the interventions, the brief interventions we can do in pharmacies, as well as your pharmacy programs specific to your country, is really an opportunity to increase this collaboration between prescribers and pharmacists. Next slide, thanks. And what I wrote in the article was talking about this dichotomous nature of community pharmacy and the perceptions that GPs and other prescribers may have of the role of community pharmacists. And I always say, are we a health professional in a retail environment, or are we healthcare providers in a retail environment? And clearly, we like to think of ourselves as healthcare providers in a retail environment, but that perception is something that is perhaps a barrier to greater interdisciplinary care. And the last point about pharmacy is really the only healthcare profession that's reimbursed for its sale of a product rather than provision of a service. Next slide, thanks. So this, you may have seen this before, Zubin Austin has described the personality traits of pharmacists. He's a Canadian pharmacist and academic. And he then mapped it to the big 5 personality types, which have been described across as a sort of communication strategy type thing. And if you just want to flick through these 5 personality traits, thanks. So they talk about openness. You know, pharmacists are accessible. Do you want to just next click through them, thanks. And we have this knowledge, and we should feel confident about our knowledge. We are conscientious. We want to help patients. We have that opportunity so often in community pharmacies. They then talked about extroversion, and not everybody's an extrovert, but that extroversion is certainly our enthusiasm, and that we want to help patients, and that agreeableness, and then the neuroticism. I'm not sure about that with everybody, but it's really that, as it was previously mentioned, that fear of talking with prescribers perhaps fits into that personality trait. And we've already heard the COM-B model talking about the capability, opportunity, and motivation, because that drives behaviour change. And that was applied to patients. And I think we can apply the same behaviour change model to our interactions with GPs. We do have the capability, we've got the knowledge and skills to help our patients living with asthma and to help them get better control of their asthma. We have access to education, such as on the IPCRG website and the Asthma Right Care program. We have the opportunity to, and we have to make the opportunity at times. And I was just speaking at another pharmacy conference here in Australia, and they were talking about the challenges of actually getting to have that conversation with the GPs. When GPs are busy, we're busy in community pharmacy. But we've got to make that opportunity, schedule the time to have that conversation, let the GP know what services that you provide, that you've got a special interest in asthma and can support our patients. And then to have that motivation to really make a change, to build that relationship with the GPs, because we know that for a particular behaviour to change, you must be capable and have the opportunity and be motivated to make those changes. Next slide, thanks. So one of the things, again, Zubin Osten has described is that are we as community pharmacists the barrier to change? And really that trust in pharmacists is more often earned than conferred. We have to earn that trust, unfortunately. We have to build those relationships and show that we are the experts in medicines and that we can support patients with living with asthma. There's been programs, we have this mystery shopper programs that sometimes highlight perhaps suboptimal care of pharmacists' knowledge and skills in community pharmacies. There is this dichotomous relationship, are we the business and the merchandising factors, and unfortunately the high degree of variability or inconsistency among community pharmacists around providing care. So we have to build that trust, and that can be challenging, but I think we need to, next slide, thanks, really use all those strategies, be confident of your knowledge and continually have that ethos of lifelong learning, because guidelines are changing all the time. There's new medicines for the treatment of asthma. There's certainly new devices and new combinations of drugs in different devices. So as individual pharmacists, I think we have the power to enhance trust in profession and in yourselves, simply by providing quality patient care. And I think that trust really underpins our relationships, and we need to work on it. We need to reflect on your conversations with general practitioners. What worked, what didn't work? You know, how could I say that differently? How could I approach the GP in a different manner? And celebrate the successes and think, yes, I've really started to build that relationship with the GP, and that will only benefit the care of patients with asthma. So I'll hand it back to Darush now. Thank you.
Thank you, Debbie. It's great. Asthma Right Care Pharmacy. Working with so many passionate pharmacy individuals, it's wonderful. And I think it will be great if we can get more followers. I'm passionately frustrated with current asthma care. I think when I think of what happens in my country, for example, where we've got nearly over 80% of teenagers living with asthma symptoms, those who've got asthma, of course, and 3 children in every classroom at school has asthma. It affects people of all ages. So let us pharmacists make that difference, and we surely are. A lot of us already are. Let's change the status quo. Let people, rather than suffer, let them live with asthma, with those nice open airways. Let's treat asthma like it should be, like it's a long-term condition. People sometimes think of it as they manage it acutely, and it's episodic, yes, but it can cause airway remodeling. It can cause scarring of the tissue if it's left untreated. And let's make every contact count. So a lot of us need to think about any time a person does have an asthma attack, what could have been done to prevent that? And we've talked quite a lot about all the things that we could have done. And one thing that stands out anytime I'm in a community pharmacy and I see a prescription for a SABA come through, I will feel quite uncomfortable with that, just to see how many have they had, and I'll check their records or ask the person. We've got tools around because we understand that people's beliefs over many, many years, as Debbie was saying, people have thought of the blue inhaler as the sort of #1 stepwise treatment. And GINA has really made a sort of bold statement and how we should be managing asthma as a condition of inflammation. So anytime if we in a country where we sell it over the counter, the SABA, find out, is it for asthma? If a prescription comes through for a prescription for a SABA, query it, question it. It doesn't need to take long, and use all these IPCRG tools that we've got to engage, to educate and empower people. So the next slide, please. So one of the tools we talked about was the reliever Reliance test and how that could be done as a self-test. I'd strongly recommend you do it this way. This pharmacist tried using it by asking questions, and this is what happened.
I don't worry about my asthma when I have my blue reliever inhaler around.
Oh, I always carry one with me. It's in my handbag the whole time.
Yeah, so on a scale of 1 to 5, 1 being strongly disagree and 5 being strongly agree, where would you say you place?
Oh, definitely strongly agree. Can't leave the house without it.
So the benefits of using my blue reliever inhaler easily outweigh any risks.
Well, I don't understand what risks you're associating with that.
So any risks that you might think come with overusing your blue inhaler, based on the knowledge that you have so far?
I don't think there are any risks in using my blue inhaler. The benefits of using my blue inhaler outweigh the risks. I would say yes, I agree with that.
So as you can see from this example in this video, that it can become an uncomfortable conversation if it's not approached the right way. So I'd say using the slide rule, using the question and challenge cards, using the reliever Reliance test as a sort of self-test, let the patient digest, absorb the information, and then hopefully behaviors will change that way. And we can, next slide, please. We can all make a difference, a huge difference. And who wants to join us as an Asthma Right Care follower to deliver better asthma care? Time for discussion.
Thank you very much, Darush, Francesca, and Debbie, for bringing us so many interesting issues to discuss and to reflect upon. We now have approximately 15 minutes for a discussion. We have received some questions from the audience, and maybe I will start by, we have some questions on therapy. So I don't think that we will be able to answer them, well, every one of them about the appropriate pharmacotherapy. But again, Francesc, maybe you can tell us how and where can people find information about the best practice in terms of pharmacotherapy for asthma. And it's a question of not giving fish to our participants, but instead teaching them how to fish. So where can we get updated information about asthma pharmacotherapy? And you've talked about GINA 2021, so where can we find the information?
Well, GINA has its web page where you can find the final recommendations. You can find the annual recommendations from GINA in that page, and is open to everyone. I don't remember just now the address, but it's open, the GINA website.
Thank you very much, Francesc. We do have a more specific question, because we are talking about SABA and the over-reliance on SABA, but is it still safe to use it for emergency situations?
Well, from my point of view, it is used. It is still necessary to use it in emergency rooms, because it provides quickly relief of the bronchospasm, but only in those cases. The daily use is not safe.
Thank you, Francesc. And I think that the message, like you rightfully mentioned, is that it has its place in care, but it cannot be the only solution, because, as we've mentioned, given that asthma is an inflammatory disease, we really need that anti-inflammatory treatment. And this is only for emergency situations. Darush, do you have anything to say about this? And I would add another question, given that we have here the opportunity to have an expert also in smoking cessation. So we have a question on smoking cessation about the use of nicotine vaping in the UK for people who cannot quit. In particular, which type of vapes are recommended, if any?
Okay, so first of all, just echoing what Francesc was saying about the importance of the SABA for emergency situations. And hopefully, and this is one of the questions I would ask a patient is, do you have a personalized asthma action plan? And I don't think every single country has their own design of one, but I think this is something that's strongly pushed in the UK, for example, because you're 4 times less likely to be, for example, hospitalized if you have an asthma plan, because you will know when to use that inhaler in emergency situations. Now, with regards to smoking cessation, we've got lots of treatments available to help people stop smoking and stay stopped, which is, out of all the things I do in respiratory, helping a person stop smoking is really the most empowering for me, because I know that that is the best thing anyone can do for their lung health. Knowing that there's 5,300 known chemicals in each of those cigarettes that a person smokes. If they're going to get a clean form of nicotine, and you can get that through nicotine replacement therapy, licensed treatments like gum and patches in many countries. The World Health Organization has got many different ones that they would have on the essentials list. But with regards to vaping, in the UK, Public Health England will have maybe a different stance to what the World Health Organization would have, or what other countries would have around vaping. My perspective is that nicotine is not the harmful chemical. It's the thing that people are addicted to. We want to get away from the tar and the carbon monoxide, anything that's involved in combustion. Vaping doesn't cause combustion. It doesn't heat things at such high temperatures like cigarettes would, or roll-ups, or shisha, water pipes. So it's nothing like that. And what we can't say is that they're safe to use. So we could always say if there is any harm, which there may be some harm, the harm compared to smoking is not going to be comparable. If I was going to recommend a vaping device, I would be positive that the person is trying to stop smoking. I would never recommend vaping devices to people who are never smokers or young people. So it's always important that if I am going to recommend one, I'd recommend one that a person can get used to and practice. So we call them first generation, second generation, and third generation e-cigarettes. And I would recommend most of the time second or third generation ones if people are going to try using them, but they would need to get some advice and counseling from a reputable organization for that.
Thank you very much, Darush. And now I will move to Debbie. You've mentioned, you said very interesting things about healthcare professionals versus retailers. And we do have a lot of opportunities by being a healthcare provider in a retailer environment because of the proximity and the accessibility that we have with people. But we have one question in the chat asking about how in this environment can we explain the risks of SABA over reliance effectively to patients. How can we do that in our environment?
Mm-hmm. It's a good question, and clearly it's challenging, perhaps in a retail environment. I know in Australia more and more pharmacies have counselling rooms, and I think that assures some degree of privacy for the patient, and they feel more comfortable perhaps sitting down in a counselling room and having that conversation. Nevertheless, you can do it over the counter as well. I think using the tools that we've talked about, like the asthma slide rule, can help just identify, and especially you might have seen it's colour traffic light coded. And when you're asking the patient how many puffs per day or how many canisters over the last 6 months have you bought or had a prescription for, that will, if it is, many patients that I see will say, oh, my asthma is well controlled. I only use one puffer a month sort of thing. Or I had a patient not so long ago who said, yeah, his asthma is really well controlled. He only uses 2 or 3 puffs a day sort of thing. So starting that conversation with the patient, trying to work out and using the asthma slide rule, and I'm using it more and more these days because they can visually see it, that they're up in the amber or the red zone as far as their use. And then we can help them understand that the harm that can occur because of overuse of their SABAs, so that their lungs might become more sensitive to their triggers, whether it's cigarettes, smoke or pollens or whatever, and using the challenge cards as well to help them understand that asthma is a chronic inflammatory disease and that it's not just about the sort of acute symptoms that they might be worried about, the breathlessness and the coughing perhaps, to help them understand that it's an inflammatory condition and that SABAs only benefit the bronchoconstriction. They do nothing for that underlying inflammatory process that's going on. So I think it is underpinned by that education and having the little sort of tubes or whatever, or devices or pictures that you can show to patients to help them understand what's going on when they have asthma. And then also, I think it's also that reassurance, and sometimes it can be a bit challenging to help them understand that the ICS formoterol, and I would stress, and I did see in the chat room people asking about other combinations of ICS LABAs. It is only the combination with formoterol because it's quick acting and it works just as quick and just as effectively as salbutamol. So we have to help patients to understand. And I sometimes say in lectures, it's a little bit like a Trojan horse, that they rely on their ICS formoterol PRN because they're getting that immediate benefit from the bronchoconstriction causing their symptoms, but there's a little bit of ICS in there to help with the inflammation. So it is a change process, and we have to, I guess, motivate patients to go back and see their GP, because in most cases you do need a prescription for the ICS formoterol. But that reassurance, and hopefully when they come back with the prescription for it, we can further reinforce those key messages.
Thank you very much, Debbie. We have a last question to Francesc, and then one really real final question to Darush. Francesc, we've talked about, SABA for emergency situations, and we have a very interesting question from Juanito. What constitutes emergency situations for asthma in general?
We have both sides in terms of hospitalization, in terms of emergency rooms, when some patient is under an asthma attack and needs some urgent help. They go to an emergency room, and there the SABAs are well used. And on the other side, as Darush have told, when you have a personalized written plan, you know in detail when and how you have to use your SABA. It's necessary to use it only in the case that you needed to use it, and you have to keep in mind when it's necessary to use it. But above all, it's necessary to understand that the track 1, that GINA recommends, is the use of inhaled corticosteroids in combination with formoterol. That is the preferred reliever, always. So, according to this, the use of SABA would be only for emergency rooms.
Well, thank you very much, Francesc. And a last question to Darush. There's, well, actually, maybe 2 questions. There's one still about the nicotine replacement. Thank you. If I understand you correctly, for a person addicted to nicotine, your recommendation would be to change from tobacco to a 2nd or 3rd generation vape. So that's a question. And the last one, we had some people asking how can they participate in the Asthma Right Care, and how can they sort of register in the program. What can we tell participants, and who can they contact?
Okay, so 2 good questions, and I could spend 15 minutes answering these, so I'm not going to do that. But just quickly on the if you're a smoker, then if you're going to go to vape, which is what's recommended in my country, then definitely 2nd or 3rd generation would be better, because you can, with practice, you can develop much nicer levels of nicotine, which hopefully will take the cravings away, because the 1st generation ones, which look like cigarettes, the cigar-like ones they're called, they're not very good, and you can't get really high levels of nicotine, which really won't take away your cravings, which is what our goal is when we're trying to help a person stop smoking. Last thing we want them to do is to relapse back to smoking, and so if the device can help them stay stopped, then that would be really good. And also think of the nicotine concentrations in the device. Now, with regards to Asthma Right Care, we've got the IPCRG website. So just please go onto that IPCRG website, which you put in the chat. Thank you, Emma. And then what you can do is look at the resources that are available. We can, so many great resources, which you can get access to. And if you want to be part of the Asthma Right Care social movement, then please contact the email that will also be on the IPCRG website as well, just to say that you would like to get involved, because we want more and more countries. This is a global movement. We've already got great examples from Portugal, Spain, and Australia and England here. There's 4 of us from different countries. And we want our team of pharmacists to just grow exponentially. You know, that's what we want. And ultimately, we want our patients to benefit from all of this expertise.
Thank you very much, Darush. And we have Sean Williams, who is the CEO for IPCRG, who kindly has included in the chat box the website, which you can visit, and also the email so that you can contact if you want more information. So with that, we've reached the end of our webinar today. I hope it has been an informative webinar for you. My final message, of course, after thanking our distinguished lecturers for today, thank you very much for this informative session. I would like to urge you to join the campaign for World Pharmacists Day on the 25th of September. So it takes just a few simple steps to create your own graphic and add your voice in anticipation of the World Pharmacists Day. So in this slide, you have more information about how you can do that and how you can share via social media the voice of pharmacy internationally. Thank you very much to all who attended, to FIP and IPCRG for this collaboration, and again to our distinguished speakers for today. Thank you very much and have a good day and